Osteobiologics 101, Understanding the Basics of Osteobiologics. By the end of this video, you'll have a baseline understanding of each of the different categories of osteobiologics necessary to help heal bone or fix bone. Let's get into it. Here we learn what all the different surgeons who work on bone have to choose from in order to help heal bone. These types of surgeons include orthopedic, all different specialties, neurosurgeons, craniomaxillofacial, craniofacial, plastic surgeons, ENTs, podiatry, etc. The types of grafts that they have to choose from include the following categories: autograft, known as the gold standard, allograft and allograft-based products, growth factor-based products, cell-based bone graft substitutes, mineral or ceramic-based bone graft substitutes, polymer-based, miscellaneous, and combinations of all of the above. This next slide shows bone graft substitutes. These are products that are not bone but can be substituted for bone. These categories include allograft-based, factor-based, cell-based, mineral or ceramic-based, and polymer-based products. We'll get into each one in some more detail later on. This slide is a matrices of decisions each surgeon must make in order to choose the right bone graft substitute for each particular patient and their clinical application. We ask ourselves, what property does the graft need for a certain clinical application? And the categories that exist are biological goals, structural goals, chemical goals, surgical handling, and the remodeling and/or resorption time. The first part of our algorithm is the biological goal. We ask ourselves, again, what properties does the graft need for a certain clinical application? This involves three different choices or possibilities for new bone growth, the first of which is osteoconduction. This supports the formation of bone by providing a structure for osteoblast attachment. Essentially, it's the lattice work or the framework for which new cells have in place to grow onto. It is important not to confuse osteoconduction with having strength. The next part of biological goal is osteoinduction. This elicits undifferentiated mesenchymal stem cells from the surrounding area that then differentiate themselves into osteoblasts that begin the process of bone remodeling. Essentially, this is the cheerleader in the bone growth process. It's not the bricks or the mortar, it's not the lattice work or the framework, but it's the necessary component in order to catalyze new bone formation. This process starts with osteoclastic resorption and then follows with osteoblast formation. The last part of the biological equation is osteogenic, new bone formation from live cells in the graft on cells of host origin. These include proteins and collagens, which is organic material. Essentially, this is the bricks and the mortar of the bone growth process. The next part of our algorithm is structural goals. Do we need structure, or is it okay to have no structure? An arrow will be provided on each slide to show us what strength categories or structural goals each category or graft accomplishes. Some grafts, it's okay for them to be low or have no structure, but others, depending on what we're trying to accomplish again in our clinical application, may require us to have similar strength to bone, or it may even be beneficial if our graft has higher strength. The third part of our algorithm is the chemical goal. Is our product similar to bone composition, like hydroxyapatite, autograft, allograft? Or is it not similar, like many other products on the market? Calcium sulfates, polymethyl methacrylate, gels, polymers, and so many other products. The key differentiation between the two is products that are similar to bone have a similar low crystalline formation like that of bone. The next part of our algorithm is surgical handling. These categories include croutons, gels and gel-like materials, granules and morsels, blocks and wedges, putties, injectable materials, sponge and sponge-like materials, and powders. It's important to remind your surgeons, even though a graft may be easy to deliver, it may not be accomplishing the structural or chemical goals necessary for that particular patient or clinical application. The last part of our algorithm, and often the most misunderstood, is remodeling versus resorption. Remodeling is a native cellular process. It is stress dependent, and the grafts used in this are replaced by native bone. Resorption is a physiochemical process. It is stress independent, and these products degrade at each of their own rates. And then there are some products that never go away. Let's explain remodeling versus resorption further. Cell-mediated remodeling. First, osteoclasts attach and excavate small pits. Then cross-linked end telepeptides are released, causing osteoblasts to form in the area and attach to host bone. Thus, we have new bone formation. Here we see the first part of the remodeling process, where an osteoclast, seen at the top right of the photograph, has dug its way through a low crystalline hydroxyapatite material. Here we see a short video showing the resorption process. Calcium sulfate and other salt fillers are fast resorbing products, and they are stress independent and physiochemically will go away on their own. Hence, they are not like bone. Now that we've explained the 5 algorithmic choices a surgeon has, let's discuss how each of those affects clinical goals. We'll see the importance of a surgeon's graft selection, his or her understanding of how it represents each of the 5 categories, and whether or not that particular graft meets the minimum requirements to accomplish that goal. The decision here combines 2 of our algorithmic choices, strength and timing. First, structurally, it needs enough strength to meet the requirement for minimum stability required for weight bearing. You'll see that on the left side or the y-axis. Second, during the course of that is time. We have the time from initial stability, when the fracture is repaired surgically, to the time when fracture is healed by new bone. Should the surgeon just use hardware alone, you can see it is insufficient for early weight bearing, as illustrated where the yellow line meets the dotted black line. Should the surgeon use a calcium sulfate, as illustrated by the green dotted line, you'll see initially it has enough strength, but soon thereafter, because it is a resorbable graft, it does not have enough strength during a period of time in which it is resorbing and bone is healing. There is a large gap, and during this gap, the patient is susceptible and the surgeon's fix is susceptible for failure. Should that surgeon choose to use hardware combined with an alpha TCP graft, you'll see initially and throughout the entire timeline that it requires for healed stability, this graft meets those goals. Therefore, it is important to understand the clinical application, the clinical goal, and how each graft represents and meets or does not meet those standards. The first bone grafting option we'll look at is autograft bone, harvested from the patient's own bone or body. It often requires a second surgical site. The advantages are inherent. It has all 3 bone-growing factors with autograft: osteoconductive, osteoinductive, and osteogenic. The disadvantages are increased morbidity and/or infection. Harvesting autograft bone often leads to more pain, limited quantities, and limited mechanical strength. Looking at the surgical algorithm for autograft, we see biologically it has all 3 bone-forming qualities: conductive, inductive, and osteogenic. Structurally, it shows low strength, only 2 to 3 megapascals. As we see, bone strength is between 5 and 22. The reason why it's lower, even though it is bone, is often it loses strength during the harvesting process. Chemically, it is bone, so obviously it is like bone. Surgical handling includes granules and morsels, often done through the harvesting process, and then blocks and wedges, often done with osteotomes with a cortical wedge block. The remodeling time for bone is 3 to 6 months. In this slide, we see autograft bone, ways it's harvested and how it looks once it's harvested. In the middle, you see a bone graft harvester. Other things that can be used to harvest bone include curettes and osteotomes. The top left and the top right is morselized bone autograft. In the bottom image, we see an example of an autograft strut. The first bone graft substitute on our list is allograft. Allograft comes from cadaveric bone that is either treated in one of 3 ways. It's terminally sterilized, it's cryogenically frozen, or it's minimally processed like DBMs and sponges. The advantages of allograft are it's readily available, it has osteoconductive and osteoinductive qualities. The disadvantages are it varies in quality greatly regardless of the company harvesting it. It has a possibility of disease transmission and offers very low mechanical strength. Allograft biologically shows osteoconductive and variable osteoinductive properties. Structurally speaking, allograft is often thought to have significant strength, but it shows lower than bone at 2 to 3 megapascals, bone being 5 to 22 megapascals. Chemically, it is similar to bone and has a crystalline structure as such. The handling qualities of allograft include granules and morsels, blocks and wedges, croutons, and powders. And the remodeling/resorption time of allograft, because it does go under both, is 3 to 6 months. Looking at allograft and the companies that process and deliver allograft products, we have many that do, including companies like MTF, RTI Biologics, Allosource, LifeNet, LifeLink, Bacterin, Miami Tissue Bank, and so on and so forth. A portion of the allograft formula is DBM, known as demineralized bone matrix. It's an allograft that undergoes an acid demineralization, leaving behind only organic components, which are proteins and collagen. The advantages are it's potentially osteoinductive. The disadvantages are it shows variable osteoinductive qualities from batch to batch. There is a potential for disease transmission, and it offers no mechanical strength. Looking at the algorithm for DBM, we see that biologically, it's only osteoinductive. Structurally, it really shows no structure whatsoever, with only 1 megapascal of strength, if that. Chemically, it has organic material like that of bone. Handling-wise, it's offered in gels, which can be sometimes injectable, and in powders. The remodeling/resorption time is 3 to 6 months. Here are some examples of DBMs. Please note, there are over 50 on the US market. A few of the more popular brands include DBX, Acel, Grafton, Opticure, to name a few. Our next category is factor-based bone graft substitutes. These are synthetically derived proteins, delivered in concentrated levels to jumpstart bone healing. Originally there were 7 identified, now there are over 150 identified by scientists. The advantages are they are extremely osteoinductive and osteogenic. The disadvantages, though, they're extremely expensive. They offer very little, if not no, mechanical strength. Unfortunately, they have the potential for mid and long-term side effects, including but not limited to ectopic bone growth and cancer. Currently, this entire category is being used less and less by surgeons and hospitals due to lawsuits because of some of these long-term side effects. Looking at the surgical algorithm for factor-based bone graft substitutes, we see that biologically they're osteoinductive and osteogenic. Structurally, they offer no structure, and chemically they are not similar to bone. They have no crystalline structure. The surgical handling options typically are put into sponges or powders, and the remodeling/resorption time is 3 to 6 months. A few examples of factor-based bone graft substitutes include Infuse and OP1, to name a couple. Our next category is cell-based bone graft substitutes. These are mesenchymal cells derived from autograft or allograft sources delivered in concentrated levels to jumpstart bone healing. Their advantages are they're osteoinductive, osteogenic, and also osteoconductive. Their disadvantages are they're very expensive in certain cases, they offer very little or no mechanical strength, and they have difficult delivery models. They have questionable cell viability, bone formation, and immunogenicity. It's important to note that this category is on the rise because of the decline of the factor-based category. Looking at our algorithm for cell-based bone graft substitutes, we see biologically they offer all the necessary components for new bone growth. Structurally, they offer very little, in 1 to 2 megapascals, if that. Chemically, they are similar to bone. Their surgical handling varies, but is mostly in granules and morsels, and their remodeling/resorption time is 3 to 6 months. Examples of cell-based products derived from autograft sources include Biomet's BioQ, the Harvest bone marrow aspirate system, Arteriocytes, Exactex, and several others. On the allograft side, we have OsteoCell Plus and Trinity offered in matrices derived from allograft bone. Next, we have biopolymers. These are products derived from natural sources, like humans, animals, and plants. Examples of these would be collagens and alginate. Advantages are some dissolve quickly, which can have its advantage. They offer different properties, like sponginess or stickiness, and they can be good carriers of cell-based products. The disadvantages are, again, they dissolve quickly, which could compromise our constructs or bone growth, and they offer very little or no strength. Here we have a look at our algorithm for biopolymers. Biologically, they're osteoconductive. Some may be potentially osteoinductive. Structurally, they offer very little, at 1 to 2 megapascals at the most. Chemically, they have no crystalline structures and are not similar to bone. The handling qualities are usually pretty nice, granules and morsels, sponges, or putties. The remodeling/resorption time, in this case which is resorption, varies greatly in this category. Here we have some examples of biopolymers. Please note that many of these products are in combination with other categories of products like minerals or allografts. Some of these examples include Vitas, Helos, and there are many other products on the market. Our next category is synthetic polymers. These are chemically synthesized polymers, or man-made. These are known as polymethyl methacrylates, or PMMA. The advantage of PMMA is that it has excellent compressive strength, and they are very inexpensive. The disadvantages, though, include exothermic reactions, meaning it heats up as it cures. It causes cellular toxicity in certain cases. It becomes brittle over time and can cause osteolysis as a result, as well as they expand during this dynamic process and then they will contract as they cure. This will cause a fibrous layer of tissue to grow between the material and that of native bone. Looking at the algorithm for synthetic polymers, we see biologically they offer zero or nothing. Structurally, they offer very high compressive strength. But again, they will become brittle over time. Chemically, they have nothing in common with native bone, so they are not like bone. The handling qualities are somewhat dynamic, and they're offered in injectable, putty, and in blocks and wedges as spacers, often used in conjunction with antibiotics. The remodeling/resorption time is null and void. These products never remodel, and they never go away. This can lead to further complications if other surgery is required. Examples of synthetic polymers, or PMMA grafts, include Cemex, Palicose, Cobalt, Simplex P, just to name a few. Our next category is mineral or ceramic-based bone graft substitutes. This is often the most misunderstood category by both surgeons and reps alike. The category includes hydroxyapatite, or HA, calcium sulfate, TCP, known as beta-TCP, calcium phosphate cements. Then you have older products like metastable glass, and then composites of all the above materials. The first mineral or ceramic-based graft we'll explain is hydroxyapatite. HA is a sintered hydroxyapatite, is a very dense material that is man-made. It's usually in a powder form and then can be mixed to set up. Some HA is in block form as well. This HA is different than alpha TCP, which will be explained later, and other calcium phosphate materials. The advantages of HA are its crystalline structure is similar to bone. It remodels like bone and is osteoconductive. The disadvantages, though, are it's very dense, and because of that, it takes 30 plus years to remodel in many cases. Looking at the algorithm for HA, we see biologically that it's osteoconductive. Structurally, it's the most impressive graft we've seen so far at 80 plus megapascals of strength. Chemically, it is like bone and has a crystalline structure as such. The handling qualities include powders and blocks and wedges. HAs will remodel, and it will take them 30 or more years to do so. The next one is calcium sulfate. Calcium sulfates have been used in orthopedics for over 100 years. Calcium sulfate is gypsum. In our case in orthopedics, it's found in hydrated form as plaster of Paris. The advantages are that it's not affected by external temperature, that of like alpha TCP grafts. It is mostly isothermic, but it actually does have a slightly exothermic reaction. The mechanical strength is similar to cancellous bone, but this is only temporary. The disadvantages are it dissolves very, very quickly in 2 to 12 weeks, leaving a void. It loses strength within days, thus it could compromise your fixation. It is not similar to bone. It is not conductive, inductive, or osteogenic. It has been known to have drainage at the surgical site, resulting in extra care for the patient. And it is 30 orders the magnitude more soluble than bone. Some examples of calcium sulfate products include Osteoset and Osteocure, which are beaded products, and MIG, which is a mixable and injectable hard-setting calcium sulfate. The algorithm for calcium sulfates shows biologically they may be potentially osteoconductive for a very, very short amount of time, but other than that, they offer nothing biologically. Structurally, they offer strength similar to bone, temporarily around 15 to 30 megapascals. Again, this will decline very rapidly, starting within days. Chemically, they have no crystalline structure and are not like bone. The handling qualities include injectable formats and granules and morsels. In this case, this product resorbs only. Resorbs fast in 1 to 3 months. Our next version of calcium-based bone graft substitute is alpha tricalcium phosphate, also known as alpha TCP. There are different versions of alpha TCP that convert and set in vivo via a chemical reaction, resulting in porous hydroxyapatite. This resulting material is similar to the mineral phase of bone without the organic materials like proteins and collagens. The advantages are significant. It's similar to native bone in structure and in crystalline form. Most have strength similar or greater to than that of native bone. Some are drillable. They remodel naturally. There's no strength deficits during healing. They're excellent for augmentation of hardware. They provide immediate and long-term mechanical strength, and they are osteoconductive. Disadvantages are, during mixing and delivery, they can be finicky, both temperature and time sensitive. They need to be mixed always, and they remodel at the same rate as bone. Some surgeons want faster remodeling. Some examples of alpha TCP products include Scaffold, Hydroset, and Norian, amongst several others. When looking at the algorithm for alpha TCP, we see biologically that it offers osteoconduction. Structurally, these grafts can vary greatly. Even the weakest one is at the low end of bone at 5 megapascals. Most are between 10 and 20, and several offer strength at 30 and higher. Chemically speaking, these will convert to HA within 24 hours, and they will have a low crystalline structure like that of bone. The handling qualities include injectable, blocks and wedges, and putties. The remodeling time is just like that of bone at 3 to 10 years. Our next calcium-based bone graft substitute is beta-TCP, often referred to as just TCP. It is a pure form of tricalcium phosphate. It does not dynamically convert like that of alpha-based TCPs, and it's typically found in granule or block forms. The advantages are it's porous, meaning it can be great for delivery of cell-based factors like BMA and PRP. It's easy to use. Some are in carriers like collagens. It's not affected by temperature. It allows for early bone formation. It's only osteoconductive by itself, but when combined with other biomaterials, it's great for fusions. The disadvantages are it's low in strength. This is a common misconception because this is often confused as just being a calcium phosphate. But when you have strength-bearing grafts, those are the alpha versions. It does not convert to HA, and it is not similar to bone. Some popular beta TCP products include Vitas, Chronos, Mosaic, and Indus. Looking at the algorithm for beta TCP, we see biologically that it offers osteoconduction. Structurally, again a misconception, it has low mechanical strength at 1 to 3 megapascals. Chemically, it is not similar to bone. The handling properties are usually in granules and morsels, powders, or blocks and wedges. The remodeling or resorption time, and in this case it only resorbs, is 6 to 18 months. The following grid is to help your understanding of all the mineral-based components we previously just explained. As you can see, when comparing the different grafts, this will help you to identify the differences between each of them. All these grafts, biologically, are only conductive by themselves. Early strength at day 1 is very high for hydroxyapatite, calcium sulfate, and alpha TCP, which will obviously convert to HA in vivo. Strength at 30 days, however, the only two that successfully stay at higher strengths than bone or similar would be HA and alpha TCP. Calcium sulfate has degraded down to the strength of a beta TCP by this point. Chemically, the only two that are similar to bone are HA and alpha TCP. As you can see, the graphs are also different in that HA, alpha TCP remodel, whereas sulfate and beta TCP resorb. And the time for remodeling/resorption is such that HA takes the longest, followed by that of alpha TCP, which takes the same time as bone. Then we have beta TCP, which is on average 12 to 18 months by itself, and calcium sulfates, which is only 4 to 12 weeks. Delivery types varies greatly between each type, and in many cases, as you'll see, grafts on the market that combine 1 or 2 or 3 of each of these different grafting substances to create one singular graft. To illustrate combination grafts, which are growing throughout the industry year after year, let's look at several of them and what combinations of ceramics they combine. Scaffold Renew is 50% calcium sulfate combined with 50% alpha TCP. Cerament is 50% HA granules combined with calcium sulfate at 50%. Quickset, also known as Structure or Graftease, is 60% HA granules combined with 40% beta TCP granules. Lastly, Prodense is a combination of 75% calcium sulfate with 25% beta TCP. Knowing how each one of these ceramics reacts will give you an idea of what each one of these grafts may or may not accomplish given the surgeon's algorithmic goals. As you can see, there's a lot to understand or misunderstand about osteobiologics. It's not important to be an expert, but important to have a baseline understanding of each of the products out there, both your own and your competition, what they accomplish, what they may not accomplish, and most importantly, how that may impact your surgeon's decisions and how those decisions affect your patients' lives.